All right. Thank you for joining the Ohio chapter of the American Academy of Pediatrics for our Lead-Free Ohio training session today. It is March 19th, 2025, and today's session is titled The Impact of Food Insecurity and Quality on Pediatric Lead Poisoning Prevention. Thank you to our funder, the Ohio Department of Health, for funding this education session and for supporting the health and wellness of children in Ohio. Next slide, please. Please read the disclosure on this slide, and thank you to the Ohio Academy of Family Physicians for sharing this education opportunity with their membership. Next slide, please. A few administrative details. Please keep your camera and audio off for the duration of the session. If you have any questions or comments while our speakers are presenting, please use the chat feature. We will have time for a Q&A at the end of the session, during which you can put your questions in the chat or raise your hand and ask them aloud. Slides will be shared after the session is completed. The planners, faculty, and others in control of the content have no relevant financial relationships with ineligible companies. Those in control of the content have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any questions or comments, please contact Dr. Kelsey Logan at the email on this slide. With that, today's session is brought to you by Dr. Joel Davidson and Jared LeBron. Dr. Joel Davidson is a general pediatrician and physician leader at Akron Children's Hospital, working with patients and families at the Locust Pediatric Care Group. An Ohio native, he received his undergraduate and medical degrees from the University of Toledo and completed his residency training at Akron Children's Hospital. He is an associate professor of pediatrics at Northeast Ohio Medical University. He now serves as the Associate Director of Ambulatory Informatics Systems and the Co-Director of Akron Children's Lead Clinic. He serves as the primary care expert for the Ohio AAP's Lead-Free Ohio program. Jared LeBron is a fourth-year medical student at the University of South Florida Morsani College of Medicine, applying into Med-Peds. He earned his Bachelor of Arts in Public Health and Psychology from Johns Hopkins University and his Master of Health Science with a concentration in biochemistry from the Johns Hopkins Bloomberg School of Public Health. He is also a research assistant at University Hospital's Rainbow Babies and Children's Center for Child Health and Policy. He is passionate about addressing social determinants of health and collaborating with community resources to develop innovative solutions for improving care for at-risk populations. His projects include developing intervention targets for lead-contaminated game-hunted meat in the Ohio Food Bank system and leveraging artificial intelligence to enhance access to social services. Thank you, Dr. Davidson and Jared, for joining us today.
And thank you, Suhavi, for the introduction, and thank each of you for joining this session. We hope that you'll learn some things to take back into the care you provide for the children of Ohio. Today, we're going to review the following objectives. We're going to talk about current data on lead contamination in shelf-stable foods. We're going to examine the comorbidities linking food insecurity with lead poisoning. We're going to differentiate between state and local resources for safe, quality food in Ohio. We're going to discuss home food preparation considerations needed to minimize lead exposure, and we're going to explore Ohio AAP's Childhood Lead Poisoning Prevention Toolkit, which we'll talk about in the coming slides. Thanks for joining us. I'm not going to go into a terribly large description about the problem of lead. We've done that session in much more detail in other venues, but today I wanted to frame our discussion a little bit by talking just about pediatric lead. First and foremost, lead is absorbed mostly through respiratory and gastrointestinal systems, mostly through inhaled or eating, basically. Acute lead poisoning and chronic lead exposure are risks for the public health of children, mostly in their neurodevelopmental outcomes, especially for young developing brains. Approximately 50% of children in the United States have blood lead levels over 1, and there's, as all of us know, there's no safe level of lead in the body. It serves no true physiological function and is a true toxin. Children that have lead exposure have a various number of symptoms, and many of them are not incredibly obvious until really high levels where you get encephalopathy, frank anemia at levels between 50 and 100. Most kids that we see in our practice, out in our communities, have very little symptoms. But on the right, we have a description of some things that you might see at various lead levels. Up at the top, some signs and symptoms of kids that are exposed to lead, and this is directly taken from the toolkit that we're talking about today, include irritability, some behavioral problems, abdominal pain or discomfort, sometimes some associated constipation, lethargy, loss of appetite or change in appetite, headaches, memory loss, and at high levels, seizures. It's really important because of the lack of obvious symptoms for exposed children that we screen and intervene early with this problem of pediatric lead exposure. And the screening and intervention is really with the goal to mitigate long-term effects of that exposure. Currently, the CDC has a reference value of 3.5 micrograms per deciliter, and that's kind of the intervention point after that, but there's no level of lead that is safe in the body. For those of you who are screening for lead in pediatric office settings, you'll be familiar with these sets of questions that are put out by the Ohio Department of Health as the recommended approaches for kids that require testing in ages less than 6 years old. And these criteria include children that are on Medicaid, children that live on high-risk zip codes, children that visit or live in or regularly visit houses built before 1950, or kids who live in or visit regularly homes that have obvious deterioration in ages of homes 1978 and younger and older, rather. Children who live in or regularly visit homes with ongoing renovation or remodeling in homes that are built before 1978, or if a child's sibling or playmate has had lead poisoning exposure. The last two questions that happen within the screening process are situations where children get in contact with adults that have hobbies that expose them to lead. These hobbies are employment, and those include areas of construction, welding, pottery, painting, and casting ammunition. And last, if children live near an active or former lead smelter, a battery recycling plant, or other known industry that generates lead-borne lead dust. If any child screens positive for these conditions, they should be screened for lead in the office. But our question today is about this intersection between food. So what about food?
All right. So now we're going to talk a little bit about food insecurity, and then we'll go into detail on the relationship between food insecurity and lead exposure. So food insecurity is defined by the USDA as an inability to acquire adequate food due to insufficient resources. There are different severities of food insecurity. So we have low food security, which is reduced dietary quality and variety, and very low food security, which is disrupted eating pattern and reduced food intake. Unfortunately, this is still a pretty prevalent issue in today's society. In 2013, 7.5 million American families with children experienced food insecurity, and more recent numbers suggest that 16 million children live in some form of household with decreased accessibility to food. So as far as screening for food insecurity, as you guys may be able to appreciate from the slides, a lot of this is really similar to how we approach lead. There's a standardized systematic approach to screening for food insecurity. And then based on the screening responses, we will then have interventions and workups that take place. So the AAP came out with recommendations in 2013, releasing a policy statement on promoting food security for all children, and then revised the statement further in 2021, ultimately giving recommendations for pediatricians to follow surrounding this topic. So first, of course, you need to screen and identify children at risk for food insecurity. These are with the two questions on the left, and these come from a larger 18-item measure that comes from the USDA in identifying food insecurity. But ultimately, these questions are quick, easy yes or no questions that have a very high sensitivity and specificity for identifying food insecurity. So those two questions are, within the past 12 months, we worried whether our food would run out before we got money to buy more. And then during that same time frame, the food we bought just didn't last and we didn't have money to get more. Based on these responses, we can then connect families with appropriate community resources. And of course, as pediatricians, we should always be advocating for our patients and their families. Yeah.
So I want to add a clinical bend to the response to patients that have been identified as being food insecure based on the questions above. The first thing I'd say is that it's very common for, well, first of all, to frame this, my office has been screening consistently for food insecurity since around 2008. And as a system, Akron Children's pediatric offices have been screening very reliably and consistently since 2013. And in our experience, the amount of people that are willing to say yes to it, either one of those questions and become positive on that screening tool is really underreported from what we know from other studies within our area. What I think this means is that when families are willing to tell a provider about those things in an office setting, in a clinical setting, that means that they're ready to talk about that issue. And there is a lot of danger in not addressing that identified need when someone is willing to share that kind of vulnerable information with a provider. And all of these situations are taken in a way that responds to the need with respect and with dignity, in recognizing that the families and the parents are after some support or some care for their children. And that's how I always frame that discussion. The other thing is that families, from what we know, don't utilize available resources as much as maybe some of us perceive. A family who's food insecure may use a food pantry like once or twice in a year. It's not that they're using those food pantry resources all of the time. However, also my experience is that families probably should use those resources more often. So being aware of what's around in your area is really critical to this response, because depending on what's available in your area may change the way that you respond to those positive questions. We have some helpful resources. 211 and 211.org can help you and or your patients search by their zip code and by their city to help them get connected with programs like SNAP and WIC. And they can use the Healthy Food Bank Hub from Feeding America to identify food banks and food resources in their area. Lastly, there's some tips on my plate, choosemyplate.gov, that talk about healthy eating and give families some ideas of recipes and appropriate composition of plates and things like that. In 2021, the American Academy of Pediatrics partnered with the Food Research and Action Center, the FRAC, and created this wonderful, very long toolkit. And the link is here on this slide if you'd like to make reference to that and check it out with some more detail. Throughout this toolkit, you have a great number of resources of things that people have tried and used throughout the country to help address this problem within their office. So if you're looking for something to how to integrate this into your practice, maybe in the same way that you've integrated lead in thinking about kind of making that more systematic and providing some beef around that screening opportunity, this is the place that I would direct you to.
All right. So one aspect that we really want to touch on with food insecurity is that most people, when they think about this topic, they think about a lack of access to food. But one aspect that we think is also important to touch on is the impact of food quality and the foods that patients are able to receive if they are food insecure. So generally speaking, families that are food insecure are more likely to live in food deserts and therefore have a smaller availability of healthy foods and a greater availability of unhealthy foods. The reality of the situation is that oftentimes nutrient poor, calorie dense foods are generally more affordable. These include things such as processed foods and shelf stable foods, which aren't inherently bad, but for reasons that we'll talk about later, they can theoretically increase risk for lead exposure.
So I'd like to talk next about the interplay between food insecurity and lead exposure. I think at the root of this issue is really that patients that are exposed, pediatric patients that are exposed to lead, live in poor housing conditions. And poor housing conditions are consolidated in areas or communities where the socioeconomic status is lower. And those are the same communities that have food insecurity. And so we know that families that have low socioeconomic status live in those older housing, lower housing, older and housing developments, and are exposed to more lead-based paint and plumbing, leading to increased exposure to their children with lead. Utilization of food banks is with regulations for certain food donations. So, patients who are in need of those food resources are going to be more likely to go to food banks. And as we're going to talk about in a little bit, have some potential exposures that we need to consider. The kind of the thing with lead is that we think about is anemia, and that interplay between a child that's micronutrient deficient is a little bit more at risk for developing anemia. And when kids are anemic, they're more likely to put things in their mouth and exhibit pica behaviors where they're eating non-food items. And that puts them at risk for getting exposed or ingesting the available lead within their environment. We have some challenges in shelf-stable foods at meeting some nutrition requirements, especially with zinc and iron within those shelf-stable products. And the degree of lead absorption is considerably more in patients that are fasting or in patients that are deficient in calcium, iron, phosphorus, and zinc. So there's a connection between this food environment and this food insecurity and a child's exposure to lead. And I'll talk a little bit later later on towards the end of the talk about maybe some of the other risks associated with lead, dietary patterns leading to lead exposure.
And the reality ultimately is that despite all the great public health advances and initiatives that have come in regards to lead, this is still a relevant issue, specifically in relation to food. So this is from a report that was published in 2022. This involves a case of a 2-year-old who was living in North Carolina and was found to have an elevated blood lead level. They did an initial environmental investigation, didn't find an obvious source, but when asking the family further information on food and spice consumption, the parents noted that the child was consuming applesauce pouches from a local retailer. These applesauce pouches were then tested and found to have lead within them.
And I want to just add a statement here on this slide. Many of us probably heard about this exposure, and many of us maybe even had to respond to this for patients that were saying, well, which applesauce pouches should I worry about? And having to think through that. And basically, this was a result of a child being exposed to lead, and then an investigation being done, a food source being identified, and then that communication being amplified through communication channels. And so this is not the most ideal system, but this is an example of how the system was able to work. And I want you to kind of, even in your own experience, think about even just a couple of years ago, being aware that applesauce and lead were kind of connected. Thanks, Jared, for giving us some more specifics about that exposure. There are other situations. Oh, go ahead, Jared.
Well, I was just going to say that it's not just applesauce that is relevant today. These are examples of products that the FDA issued recalls on due to concerns for lead. These included cinnamon, different beet purees, and dried plums. And these are all places that you would traditionally find at ethnic stores. However, these are just things to consider for patients that have elevated lead levels with no obvious source.
So the first talk that we gave earlier, just a couple of weeks ago, colleagues of mine, Dr. Tucker and Dr. Newman, talked about some of these exposures and the cases that they were reviewing, and kind of delved into this topic with a little bit more detail. So I would encourage you, if you haven't accessed that resource, we are going to make that available so that you can explore that in more discussion. But they specifically talked about like turmeric, for example. The reality is that the smaller the market environment, the harder it is to regulate that exact content of lead. And not all of the food in our food system is screened for lead. And there's no like process in place to do that. But some of the larger companies have a stake in making sure that their products aren't contaminated with lead, and are maybe a little bit more aware and more able to get those products off the shelves quickly. So the other take home point here is that if you have a patient or a family who's exposed to lead, and you've done a thorough public health assessment has been done and nothing has come up, think about possible food sources. And we don't want to make people scared of eating, but we also want to think about potential exposures. The next take home point here is also to encourage variety in diet, and making sure that you're not sourcing, one particular, you're not eating the same thing over and over and over again. If we can vary diets, we'll vary exposures, irregardless of kind of maybe even some of those unknown sources. So thank you, Dr. Newman, for putting in some references into the chat. So if you want to explore those further. But Jared, we're all really excited for you to tell us about some of the things that you learned about in your research. So.
Sure. Just to give a little bit more background context, a lot of my research is involved in investigating game hunted lead contaminated meat that is in the Ohio food bank system. And just generally speaking, the vast majority of meat that goes to food banks and food pantries comes from grocery stores, wholesale retailers, et cetera. However, some states such as Ohio, where hunting is a very common activity, a lot of this meat that gets hunted ultimately gets donated to the food bank system. Ohio is actually top 5 in total amount of donated game hunted meat. It's around 100,000 pounds annually. Now, due to this being traditionally what hunters use, and also from an affordability perspective, hunters will oftentimes use lead ammunition. Now, as you can imagine, if a bullet were to enter an animal, hit maybe a bone, it can break off into a bunch of different fragments, oftentimes way too small or distant to be easily detected. And you can see this image on the bottom right that took an X-ray of an animal that was recently hit with a shotgun pellet. And you could see the wide dispersal of lead fragments. So there has been prior research done on this topic entirely. There was a study in 2008 done through North Dakota that looked at Wisconsin state food banks that took samples of ground venison that came from hunters, and they found that 15% of that meat had visible lead fragments in it. And furthermore, the concentration of those samples were high enough in lead that it would significantly shoot up the blood lead levels of a significant portion of the children that theoretically would be consuming that meat. Currently, there are only 2 states that actually do anything about this topic. It's Minnesota, which will literally X-ray the meat as it's brought from meat processor to food bank. And if there is, if lead is identified on the X-ray, then they'll just discard the sample entirely. And then Iowa, which will put warning labels as evidenced in the bottom right-hand corner, which essentially says buyer beware. Of note, Ohio doesn't have any specific safety regulations in place for this lead exposure specifically. So I think the real thing that we want to try to drive home here is that these 2 seemingly different topics, food insecurity and lead exposure, are a lot more closely related than may be appreciated at first glance. And to that end, we know that food insecurity can lead to a myriad of negative health outcomes. And similarly, lead exposure can also lead to a bunch of negative health outcomes. But the reality is that there is the overlap between these 2 can theoretically compound on one another and really impact patients that are affected by both of these living conditions.
I want to talk a little bit about some of the comorbidities linking food insecurity and lead exposure. We've tried to outline those in this Venn diagram, with food insecurity having some effects of micronutrient deficiencies, which lead to weakened immune function, and also compounded by diet-related metabolic disorders, with the shelf-stable foods and the lack of or the availability of high-calorie but nutrient-poor foods within shelf-stable foods. Lead poisoning really having some direct neurotoxicity as its main component, also has some other end organ system toxicities with specifically liver and kidney function, and maybe even the GI system and slowed GI motility. But together, each of those kind of share a cognitive and developmental impairment commonality, as well as some mental health and behavioral impacts. Stunted growth and anemia are things that are really present in both kids that have food insecurity and lead poisoning.
All right. So now that we've gone into these topics, we want to talk about resources that you guys can hopefully incorporate into your daily practice, or at least use as reference. And again, these slides are going to be available for you guys to reference later, and we encourage you guys to look at all these resources. So we broke it down into food safety, food access, and food policy resources at the national, state, and local levels for you guys to all consider. So in regards to food safety, we have the USDA, the Food Safety and Inspection Service, which is a great resource generally for just ensuring food safety and food defense. And then at the state level, we have the Ohio Department of Health and the Ohio Department of Agriculture, which have respective food safety programs and divisions, ultimately aimed at reducing foodborne illnesses, ensuring safe cooking practices, and giving educational outreach such as product recalls. And then finally, you can always reference your local health department, which can give information that's more specific to your area. One small disclaimer is that a lot of this information is really aimed at restaurants, I would say mainly, but we're going to go into some information that you can provide to patients that can help them improve their food safety practices. In regards to food access, we have the USDA Food and Nutrition Services, which provides a ton of great information on federal nutrition assistance programs, WIC, SNAP, et cetera. And then we have the Ohio Department of Health with their Healthy Eating Initiative, which provides nutrition guidelines, toolkits, information again on just food preparation, and ultimately hoping to improve access to healthy food statewide. And then at a more local level, we have the Ohio State Local Foods Directory, which can give great information for families that they can enter their information of where they live and get access to local farmers markets or other relevant food sources. And then similarly, we have the Ohio Association of Food Banks, which provides information on any of the 12 statewide food banks and their respective food pantries that patients can access.
And each of these blue underlined is a link. And so when you get access to these slides, you can actually just click into each one of these and it'll open up the appropriate web page for that resource. So make sure you check that out.
And then finally, we have food policy. So, I mean, these are all just great in general national resources, USDA, FRAC, which was already touched on, the CDC, and then Hunger Free America, all groups aimed at ultimately improving food policy, food safety, and food access for children and families in need. From a statewide level, we have the Ohio Food Policy Network, which is comprised of a group of different stakeholders involved in the food system as a whole in Ohio. That ultimately has the same mission as the national resources, but more specific to Ohio. And then similarly, on a local level, you can also just search up your local food policy coalitions if there are specific questions, concerns, or information that you're curious about within your specific region.
So if you recall, our third step in addressing food insecurity within the office is to advocate. And each one of these resources is helpful to provide some background to what's happening in food policy, but it's also a great place to start if you are a passionate advocate around some of these topics. These are great places to start. And that'll connect a little bit to one of the offerings that we have coming up later on this spring. I'm going to now talk about some ways that you can talk to families about what to do within their home environment when looking to minimize lead exposure. And this is also, again, coming from our lead prevention toolkit. And we have this clean, cook, and cover. Cleaning is using a vacuum to regularly clean up lead hazards. And when available, using a HEPA filtered vacuum. The Ohio Department of Health does have a listing by county of which counties have available HEPA vacuums. And that resource is quite helpful in trying to help patients and families navigate towards those resources. Many times you need to rent a HEPA vacuum from one of those entities. It's too expensive to buy on your own. And then what I talk about a lot is using a wet washcloth frequently to wipe down any flat surfaces to make sure that they're free of any dust or debris, because dust that's created within the home through friction and breakdown is a very, very common source of that gastrointestinal and aerosolized ingestion of lead. So the more that we can keep those surfaces clean, that does help a little bit. And it's something that families can feel like they're doing something. Last is mopping the floors with a wet mop at least once a week. Those, of course, are hardwood floors or non-carpeted surfaces. In terms of cooking, families that live in homes built before 1978 do have a risk of lead within some of their piping and water systems. So recommending families to run cold water for 1 to 2 minutes before using it to cook or drink, and using only lead-free cultural powders, spices, and seasonings. We touched on kind of identifying some of those things in earlier parts of our talk, but even just kind of minimizing known sources of those kinds of things is really important. And then last, related to cooking, is that it's really important to use lead-free pots and pans. Some of the older aluminum pans, some Pyrex dish cookware are very common things that are present, as heirlooms that have been passed down for many generations. There's also the risk of many families having some things donated to them from others, well-intentioned people, and really families will have to have that cookware evaluated in order to know if it actually does have lead in it. But making sure that we're talking about that with them and they're thinking about what they're cooking their food in. Last is the cover. So covering any bare soil with mulch or grass. We still have a large environmental legacy when we used leaded gasoline. There's more lead in soil in kids who live near freeways, for example. And you can minimize that outdoor environmental exposure by covering the soil with covering any bare soil with mulch or grass. And an important history question with kids that are exposed to lead is, do you play outside in bare soil within your environment? Also, if families like to garden, and we're talking about like food coming from soil, you want to try to recommend that they're using a raised bed if they are in communities that are known to have lead risks, and that mostly a good rule of thumb is to use plants that grow above the ground rather than grow in the soil. So growing in the soil example is a sweet potato, whereas a tomato might be something that's grown above ground. The tomato is going to be a little bit safer in terms of risk. Covering up any chipping or peeling paint within the house. Paint is the most common exposure, and peeling and chipping paint that kids get exposed to should be covered up with a lead-free paint. If the lead-free paint's not available, you can recommend families to put some duct tape over that area, especially like windowsills are a very common source, and or creating a barrier to the access to that part of the home. So, putting up some fencing or putting up some kind of a thing that doesn't allow the child to have immediate access to that known area of chipping or peeling paint is helpful. And last is using a water filter on your kitchen faucet to remove any contaminants, or at home using some filtered water. The next thing that we want to talk to families about that are exposed to lead around around our anticipatory guidance is nutrition. The big three in lead is making sure that they have good iron source, that they're taking enough vitamin C, and that they have an appropriate amount of calcium. Now, calcium in milk has a double-edged sword characteristic to it. Milk is not the only thing that has calcium. It is a fortified element of milk in our food environment. So some milk is good. Somewhere between 12 and 15 ounces of milk in a day for a toddler is appropriate to give them adequate sources of calcium. But too much milk will actually also inhibit the absorption of that essential nutrient of iron. And so I often talk to my families about how much milk that their child is drinking and make sure we have that conversation about what's an appropriate amount. But iron, calcium, and vitamin C are the big three. So oranges is what everybody thinks of. That's what we put on the infographic. But other sources of vitamin C might be things like the sweet bell peppers, for example. The other thing that we were learning about as we were preparing for this talk was there may be some relationship between lead absorption and excess calorie consumption and ingestion of high saturated foods. There was a study that did some linear regression about some of those etiologies. Didn't make a causal connection, but there is certainly a relationship between kids who have a higher calorie intake and kids who have a higher saturated fat intake in increasing their lead level, regardless of their risk of lead exposure within the home. So something to talk about with families. The big thing that comes to my attention as a clinician is families want to know what they can do in their child's diet to remove lead. And I want to stress the point that these dietary interventions that we talk about are optimizing nutrition to help reduce the risk of anemia and thereby reducing the risk of pica, non-food item putting in mouth behavior, and not chelating anything out of a child's body. None of these, there are no nutritional interventions that act as chelating agents. And if you need a child, if a child needs to have lead removed from their blood with levels of 45 or higher, the chelating medications do that activity, but diets don't have an actual use in reducing lead levels. And so that's a caveat, and a lot of families want there to be something. And nutrition is certainly something that families are able to focus on in their response to a child who's been exposed to lead, but it's also not the end-all be-all solution to their issue. The big underlying issue is getting the child removed from a lead risk environment and identifying those sources and avoiding them. Okay. I'm going to move on now and talk about this incredible resource that the Ohio AAP has in the Childhood Lead Prevention, Ohio AAP's Childhood Lead Poisoning Prevention Toolkit. And this toolkit, here's like a screenshot of the different kind of topics that are addressed within this toolkit. We're going to have some QR codes that come up in some of the next features here, but basically this toolkit goes into some of the background and introduction of lead with a little bit more detail than what we covered today. Talks about some anticipatory guidance topics that you can use in your office. We have links to the Ohio Department of Health screening guidelines and the questionnaire that we reviewed earlier. Some advice around how to address screening and testing and how to set up a good program for that within your offices. A lot of people want to know how the Ohio Department of Health works and what happens in sequences when their kids are identified and reported to be elevated. And this section will kind of go into specific detail about how the health department responds and what to expect at different steps along the way. We have a section because of some of the legal implications that are often present. Many families, in my experience, that are exposed to lead live in rented environments, a lease or not a lease, but not owned homes. Certainly lead can be present in Ohio has a large number of homes that were built before 1978 that people do own, that people do renovate. So we need to think about this not being just a isolated people who rent problem, but by and large, there are more people who present positive that are renters than owners. And this section will kind of go into more detail about what are some of the legal resources around our area that can help those families. Because a lot of those interventions are not medical interventions, but they are legal. They have legal ramifications, and often I talk to families and say, I have this resource for you, but I'm not an expert at lawyering the housing law for you. But I know that you need to connect with somebody who does understand that really well. We also understand that the integration with the electronic health record is really important. I have a lot of experience in this space, and we've outlined some things that you need to consider and have available some phrases that you could use if you're planning on developing a good screening and response program. We're going to go into some more details about some of the resources that we have for families to use. One of those resources available through the Ohio AAP and this Lead-Free Ohio program is a rack card. This is like a third of a sheet sized front and back that kind of talks about the different elements of lead exposure, some quick facts about lead, some idea of where lead risk exposure is highest in our throughout our state, and then kind of what to expect at various levels of lead responses, and then some of the things that we've covered in terms of anticipatory guidance and topics are also outlined on the back of this rack card. We also have an appointment reminder card. This is the one half of that card. There's another half, but the slide got a little busy. I would encourage you to click on this QR code and look into the website that has all of these available resources on this page. But this card is designed to give to somebody who you're screening or whom you're intervening with, and it gives them a good idea of some things that they can do, but also helps you to be able to circle for them, like here's where we're going to focus our efforts for the next step of your child that's been exposed to lead. Of course, with resources to Ohio Healthy Homes and the Ohio Department of Health integrated into those as well. And then we finish out the toolkit with a section on questions and concerns. So with that, this slide kind of shows you kind of all of the various references. If you're someone who likes to read into more details of some of the things that we talked about, we know our audience today is variable. So if you have some interest in the two topics that we talked about with lead exposure and food insecurity, this is a great place to start. And with that, I will first of all say thank you very much to Jared. Jared is a very knowledgeable fourth-year medical student who was invited really because of his level of expertise and the research that he's done with this intersection of food and lead. But Jared's also been really instrumental in planning and putting together the content for today's presentation, along with a lot of my guidance, but Jared's done a fantastic job in preparing this, and I really want to thank him at this time. But what we'd like to do now is open things up for any questions or discussion that people would like to have around this topic.
Let's see, we have a question in the chat from Yolanda Moore Forbes. With the potential for lead contamination of venison, should we be advocating for x-rays of deers before it has been donated?
Yeah, so I can talk a little bit about that topic. So the reality is that it's a tough balance in balancing both this potential exposure for lead and for decreasing the total amount of meat that's ultimately donated. Minnesota rather, has a pretty robust system in place that is in coordination with the Department of Natural Resources and the Department of Agriculture in developing this entire protocol for x-raying the meat. And theoretically, this does indeed, decrease this exposure risk of lead. They're still finding annually roughly like 5 to 12% annually still of donated samples still has visible lead fragments that they need to discard. So all that's to say, it's kind of a tricky situation, and that is something that we could theoretically be advocating for. It's just that there are many stakeholders and systems at place, pushed back by the NRA on the topic of lead ammunition entirely, that make it a little bit of a touchy topic, but definitely something that warrants further investigation and intervention, in my opinion.
I'll take a little stab at this question. Thanks for the question. I think there's a lot of practical considerations here. How many old X-ray machines can we get donated to local food banks, and how would that flow work? And how do we balance that need for lead assessment with other food safety concerns for that donated meat? I think that X-raying the meat is probably resource intensive, given all of those kind of logistical constraints. One of the things that I think is a good place to start is actually just encouraging individuals who are donating donated meat to think about this. And I don't think, if you looked at any of those that are donating that said we know that there's 5 to 10% of the meat that you bring to us that has lead in it. I don't think that they're trying to poison children by that donation. And I think we have an opportunity to partner with those individuals and say, maybe this is a good situation where are you willing, if you're willing to donate it, are you willing to use lead-free ammunition that we know is more expensive, but it is more consistent with the safer delivery of what you're hoping to do for families. I think that that's a very practical place that we can start around advocating around this topic that doesn't require some of the logistical constraints of X-raying.
Thank you
I
both.
see. Oh, go
We
ahead.
have another question in the chat. Years ago, there was a big scare on toys made in China. Is there still an issue with this?
So I will say toys are still an issue. That it's not specifically China. There are lead paint has not been abolished throughout the world. There are still sources of lead based surface coatings in many countries. And Dr. Newman, I think, talked about the specific countries that Dr. Newman and Dr. Talker talked about this in their talk a couple weeks ago, their first talk of the year. So I would reference their slide there. The reality is that there are still, yes, toys that have a potential exposure. The health department assessors that come out for kids in Ohio that are over 10 and do that complete multi-hour assessment of lead risks within a home should be looking at some of those sources. And I think I don't know if any of you have been in a retail store anytime recently or been up to the service counter, but there's always a long list of recalled items. And I try as a pediatrician to check those items. But the, the short answer is yes. However, we also can't make kids afraid of playing and afraid of interacting with things. So um, I think we have to, it's something to think about. Especially if we have items that are being put into their mouths. Another consideration as we're talking about toys is older toys. So, a paint that might have been used in a 1950s environment that's a really cool toy from grandma or grandpa is something that you need to be aware of.
Thank you, Dr. Davidson. The next question in the chat says, if a child does not have a lead screen done by their pediatrician at the time of the physical or well child check, what are the recommendations?
I would say so. When I'm most proud of the work that we've done in our system is when families come to me and they say, "I'm worried about lead. Can you test my child's lead today?" And I say, "Well, we've already, like, tell me a little bit more. Have you moved? Has there been any other exposures?" And in my practice environment, we're regularly screening and testing those kids. So I'm looking back and I see that they've had, the maybe the 2 tests that they're required to. They don't have any additional history, and I kind of reassure that family like we're doing good. We don't need to test. Or other times I have that situation that comes up, and I say that's awesome that you're thinking about that. Like, we do need to test your child today. So my recommendation is to talk to families about that need to screen. Take a look at that screener, understand which children should be screened, and make that recommendation that they go in and talk to their doctor and get their lead screened is a great opportunity.
Thank you. We have another question. Can you discuss breastfeeding if mothers who may be exposed to lead increase exposure to the child?
So we do need to think about breastfeeding moms. Lead can be ingested in the mother and passed on via breast milk. I think Dr. Newman made reference to this specific question with a little bit more detail during his talk a couple weeks ago. Sorry to reference that so much, but he gave a little bit more specifics about the exact risks that present themselves. But when I have an infant that's breastfeeding and or a mom that's pregnant with another child, a second child or a third child, I always talk to them about the importance of them getting tested and them talking to their doctor. The OB community is not as aware unless that topic gets brought to their attention. But the keywords there are my I have other children that were exposed to lead, and I would like my lead tested. Um, and that can be contextualized.
Thank you. To the person who asked that question, Dr. Newman responded to your message and said it is recommended to pause breastfeeding if a breastfeeding mom's lead level is greater than 40. And in my follow-up email, I will also include a link to the session that we did just a few weeks ago. It was really great, and I'm always happy to reshare our education. So thank you, Dr. Davidson, for plugging that. We have a comment in the chat about the hunted game meat, I think, that says labeling akin to Iowa's policy also seems like a reasonable first step in a similar spirit to the Great Lakes fish consumption. So thank you for sharing that. We have another question. What is the best way to check old cookware? And are brand name spices as common for lead as imported spices?
All right, the best way to check old cookware is probably to have the health department take a look at that. So I would refer you to your local health department resources. There are available like kind of small at-home test kits. Those test kits are reliable if they're positive. They're just expensive, and you can only use them on 4 surfaces. So um, I think some basic background research is kind of necessary, and this is where the internet can kind of help a little bit. I'll give a personal example around the Pyrex dishes. My grandmother had some beautiful pink Pyrex set, and I actually knew that this set was um, not this specific set, but I knew that that was a risk because of the work that we do. But my mom brought it, and she's like, "I really want you to have this," and my wife was super excited to like use them, and I was like, "We can have them. We're just going to put them in the cabinet and put some plastic around them." And I didn't actually test them. I knew basically that they're positive. Um, so I think don't I think testing by visual is not great, but really Dr. Newman also talked in the previous talk about how to talk to families about environmental exposures. And really, this comes about in a way that's like, tell me about what you use to cook your food with, kind of just listening to those exposures. Like, where did you get those from? Like, did you bring anything with you when you came and resettled here? Um, there's some great history questions, but in terms of the actual testing, the health department really is best situated to provide that. And some of that testing, when child is not identified as being high within the home, is actually expensive. And cost may be a barrier for some of those tests. In the same way that the testing kits are expensive, doing an independent evaluation is also expensive. So it's just calling out another barrier. The second part to that question, are brand name spices as common for lead as imported spices? And the answer to that is we don't know. Um, we don't regularly test these things, and we don't have a system for regularly evaluating those things. So that's the answer to the are brand names more common? The reality is that not always. We do think that there's a little bit of vested interest for larger companies to keep track of these kinds of things, like where their food sources have elevated lead. For like a big company, big box store does not have a vested interest in generating that negative press, and may have more economic pressure to check for those kinds of things. But the reality is that it's not regularly being screened for, so it's difficult to say.
Thank you. I will share the last question in the chat, though Dr. Newman did reply. Somebody said, why aren't newborns being tested for lead after they're born and before the 1-year checkup? Dr. Newman said, studies have shown that lead levels in children who live in high-risk environments do not start increasing until 6 months of age. Testing at-risk moms during pregnancy makes more sense. I should add, Dr. Newman is part of our Lead Free Ohio medical leadership team. He is our subject matter expert and personally and professionally very passionate about lead poisoning prevention in children. So thank you, Dr. Newman, for chiming in. Dr. Davidson, if you would like to add anything, please feel free.
All right, so then there's a question from a local health department who doesn't have specific resources. I would refer you to the state Ohio Department of Health and talk to our colleagues there. In terms of, yes, every county does not have robust resources for lead testing throughout Ohio. There are some more regionalized approaches and contracts related to the assessment pieces, and the assessment pieces are tied to the available equipment for testing. So I think if you are a representative of a health department or working with a health department locally that's not able to do those things, um, uh, our health department, Ohio Department of Health colleagues are more than accessible. They are very interested in trying to solve these kinds of problems. And in my experience, have been excellent resources. So I would just reach out to them.
Uh, Philip from Columbus Public Health said turmeric is a lot safer. The problems we typically find today for turmeric are usually from spices brought back from travel overseas. Thank you, Philip. We have one more question in the chat. If a mom is not tested during pregnancy, is it best to start having babies tested at their 6-month checkup for offices to put in place?
It is possible to test at any time that child's developing, like hand to mouth behaviors, especially at increased mobility. And so the guidelines are set up for at risk testing for 12 and 24 months old. But if you feel like that there is a risk based on history, you are welcome to screen earlier. And some practices are screening at 9 months instead of 12 months. And the important thing I think there is that you're screening at all, and really thinking about this problem. So Mackenzie, I think you're on to like thinking about this problem, and that's I think the first step, and that's what we're really trying to get most of the providers in the state to kind of start to think about is it's like when would it really be most appropriate for me to think about this, and talk about it with my families. So thank you.
I will echo Kathy's comment in the chat. Thank you for this information. It's been a great discussion. Thank you so much, Dr. Davidson and Jared, for presenting today. We're greatly appreciative of your time. So if we could go to the next slide, I have just a couple of QR codes that I would like to share for some upcoming education and advocacy opportunities. On this slide here, please join the Ohio AAP for our Spring Advocacy Day on Thursday, April 10th at the Ohio State House. It is critical we advocate for the children and families in our care, and the Ohio AAP is eager to help you make your voice heard. We will have an Advocacy 101 and 102 learning session, followed by optional group legislative visits. You may register by scanning the QR code on the slide, and it will also be in my follow-up email. I'll leave that up for a second.
Oh, sorry.
All right, next slide, please. If you're looking to improve your practice's lead office flow and test ordering and completion, the practice coaching program is just for you. A mix of quality improvement techniques with the time commitment of education, this is perfect for making sustainable changes without the lift of an MOC Part 4 project. Participants in our Wave 1 saw an increase in test ordering and completion, and all participating practices share that their practice workflow had improved throughout the project. This program will kick off in late summer 2025. Please scan this QR code to complete an interest form so I can contact you as we approach the kickoff. We're excited to help you make sustainable change. I will also include the link in my follow-up email. Okay. The exciting part, please check your email to claim your CME or MOC credit. We ask that all participants complete the short survey, even if you do not plan to claim credit. This will enable us to collect endpoint data to measure the rigor of our programming. Once you complete the survey, you will receive a certificate within 10 days. I will follow up with these directions via email for your reference. Next slide. If you have any questions or suggestions for future Lead-Free Ohio programming, please call or email me at the contact information listed here. This concludes today's training session. Thank you for your time and energy, and I hope to see you in another Ohio AAP training.